Just to a brief about why clinical guidelines are important for clinicians to ensure very optimal and outcome-oriented care. They are recommendations which are based on certain systemic methodology and research for specific conditions in clinical medicine, and they are perhaps one of the best evidence-based recommendations for taking care of patients with clinical situations. The actual definition comes from the Institute of Medicine. Now, why do we need guidelines? Of course, as I mentioned earlier, they can give you the best evidence-based recommendations for taking care of our patients. Now, given the fact that there are a lot of variations in the clinical care, given our variations in experience, our skills, knowledge base, such recommendations probably are sine qua non for good clinical practice. And such variation can actually impact the quality of care that is delivered and also impact the cost of care. Now, these recommendations can actually bridge the gap between what the clinicians can know and offer our patients and what scientific evidence holds good. So when we talk about the advantages and benefits of such recommended clinical guidelines, they definitely improve the quality of care that we can provide to our patients, improve the validity of the clinical decisions that we can make in given situations. And of course, once we follow them as a general, we take them as a general guidance, we can definitely ensure that our practices and care of patient is not ineffective or does any harm to our patients. And based on these recommendations for each of the clinical situations, we can evolve our own care pathways or algorithms of management, which we can ensure is standardized across our systems of practice. Is especially useful in situations where there is no single practitioner, like in teaching institutions, medical colleges, academic institutions, and large volume care centers. As I mentioned earlier, such guidelines in clinical practice can also facilitate us to identify any gaps that are on clinical practice, and that we can seek research on to improve or fill these gaps. And of course, this can be a double-edged sword when it comes to medical legal issues. When we follow this guidelines strictly, it's possible that when there is a contest, when there is a legal contest from one of our patients, we can always refer to that we can say that we have followed what are the guidelines and just that the outcomes were not very optimal. And there is also a provision that certain payers like insurers they want to know if the practitioners have adhered to certain recommended guidelines, and only if that is done, they will be willing to pay for the cost of the procedures. So the limitations, sometimes not all guidelines can be perfect, depending upon how they have evolved, and depending on whether complete validated evidence were present or not. Some of the recommendations can be defective or flawed, which can of course compromise the quality of care. And sometimes when we, as I had mentioned earlier, if we do not follow the recommended guidelines, the payer can refuse reimbursements. And the managers who are non-clinical people, healthcare managers, they are just trained to assess the quality of care we provide based on these recommendations. So when you try to customize certain clinical decisions based on individual patient requirements, they may see this as a gap in clinical care that is provided. That's a major flaw, or I won't say flaw, a drawback of clinical guidelines. And of course, it could be a citable evidence for malpractice litigations. Sometimes, patients These guidelines are open. Anybody can access them on the internet. And we have seen patients contesting legally. So recently we had a patient who was detected to have significant anemia post cataract surgery, and even full cataract surgery, 6/6 vision. But she developed macular edema, for which we did certain investigations to give intrathecal injection. She was found to have a hemoglobin of 3. So she went against us legally in the consumer forum, saying she was not investigated for anemia prior to cataract surgery. So we had to tell the Honorable Court that no guidelines for cataract surgical procedure says that hemoglobin has to be checked. So that's what saved us the day. The same time can also go against us. We have a physician whom we operated, and he said that my corneal thickness is it's very high. It's order of 600 plus. And the doctor had not taken this into consideration while deciding to do surgery. So the doctor has needlessly performed surgery for pecuniary benefits. So these are the ways that guidelines can also go against us. And as I will mention later, informed decision making is very, very crucial. This is not a failure of the guidelines or failure of the system, delivery system, but a failure of communication. So again, these guidelines can have several benefits to the healthcare system in general. For example, standardized treatment can optimize the cost of healthcare delivery. And of course, in large volume centers, standardization and adherence to treatment guidelines can improve efficiency. We find this hugely beneficial in situations like ours, where we have a lot of doctors in training, like postgraduates and fellows. And of course, by adhering strictly to these guidelines, we can ensure that the quality of care we provide is of excellent level. Of course, to individual patients, they can ensure better health outcomes. And when they need to meet different providers, whether either within a single hospital system or even outside, adherence to these guidelines, can provide consistency and continuity of care, which is very, very critical for ensuring good outcomes. Most important, these guidelines can empower patients to take an informed decision making. But I had said earlier, we need a very thorough, clear-cut communication to ensure the patients are empowered or not, and not disinformed or disempowered. And when a patient has a certain, he has a hesitation in accepting the treatment you are suggesting, say you are suggesting surgery all of a sudden because glaucoma is progressing. So he may not have the confidence, or he may not be willing to undergo surgery. But by referring him to such guidelines, you can just say, you are progressing based on these parameters, so the recommended treatment is surgery for you. Probably the acceptance would be better, because he would be more confident in our recommendations. And because if these recommendations are clear-cut and well-defined, the decision making, not only by us but also by the patients, can be much more easier and evidence-based. It can also cause potential harm, as not all guidelines can be of the highest quality. If they are defective or flawed, we can end up in providing a suboptimal quality of care to our patients. And sometimes recommendations can not be very cost effective. For instance, you have a very early glaucoma, intraocular pressure is controlled on a single drug, and requires cataract surgery. So the recommendation is to go in for a stent, trabecular stent, like an eye stent, or even a hydrous implant which has been introduced. Its outcomes are good, but prohibitively expensive. It may end up with a 200,000, which is almost 5 times the cost of trabeculectomy, or even a excisional goniotomy angle surgery. So the key shortcomings, if you summarize, these guidelines are sort of systemic and they are not customized to individualized care. In fact, they say that they are more focused on disease rather than on the patient. That's where we have, as clinicians, we have to be very careful and responsible. And most guidelines can have methodological limitations because not all of them rigorously follow the methods that they should follow for systemic review, generate evidence, and recommend the guidelines. Sometimes the information can be outdated. Most guidelines may not be updated and validated periodically. So you end up, you are not dealing with the advances in the current knowledge if it is not incorporated in the recommended guidelines. So that you need again to be careful. And all said and done, there can be a lot of difficulties and challenges in adhering to these guidelines in clinical practice. And again, as I said earlier, they don't focus on individual patients. So that they are not contextualized. They don't, it's impossible to recommend to each kind of clinical situation a generalized recommendation. So these are for rather generalized recommendations that we need to take into account, and we need to have them as a sort of a framework in which we will, as clinicians, we will have to be updated and take the decision that will be most beneficial to our patients. So how do we know that the clinical guidelines are reliable and trustworthy? And of course, the Institute of Medicine has come out with several recommendations which need to be fulfilled. And if you say, just to say an example, even the American Academy of Ophthalmology practice patterns for primary open-angle glaucoma does not meet 4 of the requirements that has been recommended by the Institute of Medicine. I'll not go into the details because we are running out of time. And there is also a tool called the G tool where you can score each of the recommendations based on certain criteria, and we can say whether these recommendations are highly reliable and trustworthy. So where the gaps exist between clinical practice and the recommended guidelines is there is a need for a strong level of evidence in most of the recommendations. And when these recommendations do not have a high level of evidence in the literature, we tend to go by our own experience, our own level of understanding. And the experts involved, they either come to a decision by a consensus or they will be having their own conflicts which come into play. Again, individual patient factors and preferences play a huge role. And as I said, contextualized resource constraints are always there. So when we say in primary open-angle glaucoma, as far as the diagnostic approaches goes, visual field evaluation, OCT are recommended at 6 monthly intervals to assess progression. Oftentimes this is not possible. Even in advanced countries like the US, only 50% of the patients have visual fields done every year against the recommended frequency. It's far less in our system. In our setup, I would say only less than 10 or 15% of the patients meet this requirement. And with setting individualized target IOP, it's often very difficult to meet the requirements what has been suggested. Sometimes in advanced glaucoma, we need a IOP in single digits, which is not even possible with surgical management. So when you say the ICMR standard treatment guidelines for OAG says you have to start with the medical therapy, going for maximal medical therapy and then laser treatment if possible, and then surgery. This is what has been recommended by the standard treatment guidelines. And even the American Academy until recently has been suggesting medical therapy as the initial mode of treatment. But then we know all the problems of the medication first approach, especially with the non-adherence, prolonged medical treatment can compromise the outcomes of surgical management when done late. And all medications have adverse effects when used over a prolonged period of time, especially prostaglandins. And recently there is a metadata study which has said even brimonidine can compromise the outcomes of trabeculectomy if it's been used for several years. So issues with adherence, patient-related factors are there. So it's very difficult if you start with medications first to totally prevent progressive glaucoma, especially in the rapid progressors. So even before any guidelines could say, we have switched to what is known as interventional glaucoma, where you do not start with medications first. You start with selective laser trabeculoplasty for open-angle glaucoma, and then try one of the minimally invasive surgeries. If these do not help, then you depend upon medications and more interventional surgeries like traps and then tubes. So this has been the changing paradigm recently. And so these are the alternative approaches which have been recommended for the conventional glaucoma treatments which have been followed earlier. Now, the current focus, I said, is on initial laser treatment for open-angle glaucoma. And recently, as I was going through for this talk, the American Academy has actually modified the practice guidelines for open-angle glaucoma. It was published recently, as recent as last month. And they have suggested initial SLT or prostaglandins. The choice is left to the treating physician. So the challenges, of course, we have a lot of challenges in accepting SLT as the first line of treatment, in spite of all the evidence that is there. And the resistance comes not from patients, it's from doctors. I've been trying with my fellow colleagues to recommend SLT as the first option for the past 2 years. But the uptake is very, very less. Less than 10% of the initially diagnosed undergo SLT. So there are a lot of challenges even with the newer. And MIGS, of course, the master is here, so we expect more from him. Just one condition, where initial medical treatment will not help is the juvenile glaucoma, highly inherited condition. Most of them present with advanced glaucoma and high intraocular pressures, which will be very refractory to medical therapy. So we need to go in for surgery. Earlier we used to offer trabeculectomy. Now we recommend GAD surgery for these patients as the initial intervention. And for advanced glaucoma, the TAG study, trabeculectomy in advanced glaucoma study, has actually recommended trabeculectomy as the initial management of choice, but it can have a lot of issues. For example, any hypotony can, in advanced glaucoma especially, can trigger aqueous misdirection or choroidal hemorrhages, compromising the quality of vision. And we know all the problems, the blood-related problems and hypotony that could be the consequence of filtering surgeries. And another recommendation has been non-penetrating glaucoma surgery in advanced glaucoma. This was published in over 300 plus patients. It was found to be at least as effective as trabeculectomy for a period of 3 years and probably safe. There were no vision-threatening complications. They was also published in the Indian Journal of Ophthalmology. And chronic angle closure post-LPI, trabeculectomy is recommended. But trabeculectomy in angle closure can have more disastrous complications like choroidals or aqueous misdirection. So the recent recommendation has been either MIGS with goniosynovial and lens extraction. Or when you prefer trabeculectomy, it is always to be combined with lens extraction, even if the lens is clear. Unresolved acute angle closure, iridoplasty is being recommended, but oftentimes not possible or very challenging. So we recommend diode CPC first to temporize intraocular pressure, followed by the trabeculectomy MIGS with lens extraction. This has not been said in any recommendation. Diode CPC has not been advised as an initial treatment for unresolved acute angle closure. So the red flags in guidelines, emphasis on disease-oriented and not on patient-oriented outcomes, not contextualized, there is no flexibility, no customized or tailor-made approach is possible. So it can have a lot of gaps when it comes to practical implementation in clinical situations. So we agree that clinical guidelines are a very critical part of good patient-centered care. They have both recognized identified benefits as well as harms which we need to recognize and act accordingly. And of course, if guidelines are rigorously developed without any conflicts of interest based on good scientific evidence, well validated, then they could guide us well. And of course, there are always individual situations where we need to deviate. And what we need to focus is on the individual patient outcome and not on any communal or systemic approach when it comes to individualized care. So most important, please involve the patients in informed clinical decision making, especially, let me repeat, especially if you are deviating from the standard guidelines, because standard guidelines are all there to see, and anything we do and if the outcomes are not optimal, patient will try to, this is what is recommended, you have not done this, so I have the problem. So we need to discuss with the patient why we need to tell what is being recommended and why we are deviating. That is the lesson I have learned from probably 20, 30 years of clinical practice. So thank you very much for your patient listening. Lovely to be with this audience again. Thank you.